Evening, everyone. Warm welcome to everyone from the Department of Emergency Medicine. My name is Dr. Vijay Varma, and it is a great privilege to present this good clinical topic to all of you. So, the topic, why we have chosen this topic is it is commonly seen in our practice, and I will not go into the intricacies of hypernatremia, but let us discuss what is clinically relevant so that this, at the end of this session, all of us will be able to practice this particular problem even more better. So my topic for today is hypernatremia in ICU or the ER setting. And the outline of our discussion would be pathophysiology of hypernatremia, clinical features of hypernatremia, and how do we approach a case of hypernatremia and management strategies. By definition, hypernatremia is supposed to be a serum sodium of more than 145 millimoles per liter. Before we get into the intricacies of hypernatremia, we need to get our core concepts right. That is tonicity versus osmolality. Your serum sodium and to a smaller extent, your serum potassium contribute to the tonicity of the plasma, whereas your plasma osmolarity, part of it is contributed by the electrolytes and also your glucose plus urea. So you are all aware of how do we measure osmolarity versus calculating osmolarity. We use the formula using sodium, glucose, and urea, right? So that's the difference between tonicity and osmolarity. Why is it important? Because if you take 5% dextrose has no electrolytes. It is fully consisting of dextrose, that is glucose. So it's a highly osmolar fluid, but with zero tonicity because it doesn't have electrolytes. So this slide becomes the basis of our discussion today. Whenever we are talking about osmolality, sodium disorders, two important things have to be considered. Two basic regulations. Our body system is divided into osmoregulation and volume regulation. Both these things go hand in hand, and they are compartmentalized systems because your plasma osmolality is sensed by your hypothalamic osmoreceptors, and thereby, whenever, for example, if your serum osmolality is increasing, your brain gets stimulated and your ADH is produced. Once your ADH is produced, what will eventually happen is you are going to excrete reabsorb lot of water, thereby causing a concentrated urine. So your water excretion is affected. Thereby, you develop either hyponatremia or hypernatremia. That essentially it means that your plasma osmolarity and the effectors of ADH will result in either water excretion or intake. So sodium disorders per se are always disorders of water and not sodium per se. This we have to get it very clearly. On the other hand, if someone's effective circulatory volume, so someone has a diarrhea or they have a cardiogenic shock or a nephrotic syndrome, your effective circulatory volume is very low. In such patients, this is sensed by your carotid sinus, afferent arteriole, and atria. And the first thing that gets activated is your renin-angiotensin aldosterone system, your natriuretic peptides. Also, your ADH and sympathetic activity also gets stimulated, but at a later stage. And what does the body try to do? It tries to retain sodium or excrete sodium. For example, if someone is volume depleted, your nature is in such a way that your kidneys try to retain sodium, thereby causing the increase in the effective circulatory volume. So your volume depletion, whether a patient gets edematous or whether they are volume depleted, this is sensed by carotid sinus, and this system is totally driven by your renin-angiotensin system. Both these two, one compartment doesn't go into the other compartment, and for a given patient, both these two compartments might be active at the same time. So Going into the topic proper, that is today's topic, hypernatremia. How does the body protect itself from increases in tonicity? For example, someone is developing hypernatremia. What are the natural mechanisms by which hypernatremia is prevented or trying to reverse? Your first in, response to hypernatremia is that we increase our water intake because it stimulates thirst. The other mechanism is because the ADH starts increasing, ADH acts at the level of the kidney at the basolateral membrane of the collecting duct, thereby resulting in reabsorption of water, decreasing the reabsorption of water, and then, decreasing the renal excretion of water, thereby resulting in water accumulation within the body. Because the body is losing water, your natural tendency is to retain water, and that is done by the vasopressin or the ADH hormone. So thirst, as we discussed, is the main defense against any patient developing hypernatremia. So it is almost for sure that someone with symptomatic hypernatremia will not develop, no one will develop symptomatic hypernatremia if such a patient has intact thirst and if he has access to water. What do I mean by intact thirst? Suppose if the patient is unconscious, he's on a ventilator, okay, or he's deeply comatose, they will not have the thirst mechanism. Or second thing is, if he does not have access to water, someone who is in a desert or someone who is totally stuck in a, for the other day, so many people have been stuck in the in North India in a tunnel, and our government took almost all the precautions to save these kind of patients. So these are the people where there's no access, they might get dehydrated and then start developing hypernatremia. So whenever your body's serum osmolality, the normal serum osmolality is between 275 to 295. As the serum osmolality tends to increase beyond 295, that is when the first thing that gets triggered off is your antidiuretic hormone. And slowly, as your osmolality increases, your ADH production also increases. But once it crosses 295, your thirst mechanism becomes significantly active and it takes over the ADH production. That means thirst is even more a protective response than ADH production itself. So factors determining the hypernatremia. If you take plasma sodium, what is it? It is nothing but your total body sodium plus your potassium divided by total body water. So as simple as it can be, your numerator, if it keeps increasing, and your denominator, if it keeps decreasing, you are going to develop plasma sodium, which is high. So whatever increases your plasma sodium, how does that happen? And whatever decreases your total body water will cause hypernatremia. Most often, if there is a decrease in water, that is called as dehydration. And if there is an increased sodium intake or sodium load or increased potassium intake, what happens with potassium intake is whenever potassium is an intracellular ion. So the more potassium you take in, the system tries in such a way that potassium has to be pushed inside the cell, and sodium, by virtue of sodium potassium ATPase, is thrown outside the cell, thereby patients developing hypernatremia. So this slide is very important to understand the basics of our body fluids. Our plasma sodium, our plasma concentration of electrolytes, if you take both our sodium and potassium, will be approximately between 140 to 150. If you look at our sweat, it consists of more of water than your electrolytes. So any fluid which is lost from the body, which does not have good amount of electrolytes, this concept is called as electrolyte free water loss. Such patients can develop hypernatremia. So if you look at gastric fluid and the sweat, their plasma sodium and concentration is around 50 to 55. And in case of secretory diarrhea, which is typically seen in cholera and certain intestinal tumors such as VIPomas, in this group of patients, the fluid that is lost is rich in electrolytes. So these are the group of patients who are more prone for hemodynamic disturbances. They are prone for hyponatremia and hypokalemia rather than hypernatremia. In case of osmotic diarrhea, again, which happens with lactulose overdose or sorbitol and certain bacterial and viral Gs, in this group of patients, they lose more water than the electrolytes. Thereby, these group of patients can develop hypernatremia rather than hyponatremia. So what are the clinical features? Anyone who is hypernatremic, his urinary osmolality is so much that their thirst system is enhanced, and therefore these are the patients who will have intense thirst. They keep drinking water again and again. However, in patients who are old enough and in the situations that we have discussed already, ventilated patients, those patients who don't have access to water, they will become more symptomatic. And whenever there is loss of water, or they might develop symptoms of marked hypovolemia, and there eventually the neurologic manifestations ensue. So whenever this slide shows what happens typically to a patient with hypernatremia, your first response to any hypernatremic state is that, so your first response to a hypertonic state is that your brain loses water from water, thereby causing slight shrinkage of the brain. And the brain then adapts by forming electrolytes. Slowly, that is replaced by formation of organic osmolytes, and the brain tries to reach back to its original size and shape. At this same time, if you rapidly correct the hypernatremia, these are the group of patients, because you are reducing the serum osmolality, water moves from the intravascular compartment into the brain, thereby causing cerebral edema. That is, while you are correcting hypernatremia, and that too if it is fastly done, it is done at a fast pace, they are prone to develop cerebral edema. On the contrary, if a good correction, slow correction is done, they return the cerebral, there is no chance of cerebral edema, and the brain size and the osmolality is maintained. So as discussed, wherever the basic causes of hypernatremia can be divided into unreplaced loss of electrolyte free water or excessive sodium intake and the predisposing factors. So loss of electrolyte free factors. So when we get a patient to the ER, these are the usual causes wherein we see patients presenting with hypernatremia. They would have lost water through burns, heat stroke, and if it's a pediatric, uh, uh, good practicing pediatric hospital, inadequately breastfed neonates. These are the group of patients. GI losses, as discussed, osmotic diarrhea, those people with vomiting, nasogastric drainage, and recently, if someone has had SGLT2 inhibitors, the new drugs for diabetes, they are prone to develop hypernatremia. And very commonly in the ICUs, we see if a patients who have had AKI secondary to acute tubular necrosis during the polyuric phase, the kidney does not have the capacity to retain so much of water. So your free water loss is much more than the electrolytes. And these are the group of patients who develop hypernatremia. And when you post-obstructive diuresis, suppose you have a severe prostate enlargement, patient is not, and with bilateral hydroureteronephrosis, sudden urinary retention for close to 10 to 12 hours, you suddenly relieve the obstruction by putting a Foley's, and these are the group of patients who will have post-obstructive diuresis, and if not adequately managed, they can develop hypernatremia. Mannitol, we commonly see that is given in the neurosurgical patients. In the ICUs also, we tend to see slightly uncommon, but most important cause of hypernatremia is the water diuresis, mainly because there is central diabetes insipidus due to deficiency of ADH, or if the kidney is not, if kidney is resistant to the ADH, what we call as the nephrogenic diabetes insipidus. Very typically, sometimes what happens, severe exercise or strenuous exercise, seizures, and electric shock, these can cause hypernatremia. Why so? Because whenever there is so much amount of muscle activity, the particle, the solutes within the muscle are broken down into smaller solutes, and there is an increase in the osmolality of the muscle, thereby drawing water from the extravascular compartment into the muscle. Therefore, that results in hypernatremia. Loss of electrolyte free water, predisposing factors. So these are the group which we have already discussed, those who don't have access to water, neonates, and ventilated patients. Causes of central diabetes insipidus. So commonly in our setting, we see it in post-trauma and in neurosurgical patients. Certain infiltrative disorders such as neurosarcoidosis and Langerhans histiocytosis, some people with hypoxic encephalopathy, these are commonly seen issues. In our clinical practice, if you look at nephrogenic diabetes insipidus, far more common than your central diabetes insipidus in the ICU settings. Very commonly missed thing is hypercalcemia, because hypercalcemia, by virtue of the calcium sensing receptor present on the thick ascending limb of loop of Henle, it is prone to cause a lot of dehydration. And these group of patients, lot of free water loss, these group of patients are prone for hypernatremia. And hypokalemia, as we have discussed, they will result in, because of the sodium potassium ATPase exchange, can result in hypernatremia. Certain drugs such as lithium, commonly used drugs such as ofloxacin, amphotericin B, tolvaptan is a culprit drug. We usually give it for correction of hyponatremia, but we end up using it more than often and thereby causing iatrogenic hypernatremia. Certain tubulointerstitial diseases of the kidney like ADPKD, sickle cell disease, and autosomal dominant tubulokidney disease, these can result in hypernatremia because the kidney doesn't have the capacity to retain water, because the collecting duct is not sensitive to ADH. And certain infiltrative diseases such as amyloidosis. Very interesting topic, excessive sodium intake. Not more than often, particularly in patients such as acute salt poisoning in Turkey and places like that, where neonates, there is a ritual that is done to avoid infants from smelling. They rub salt on into their armpits, and because the neonate skin is very fragile, there is significant absorption into the systemic circulation, thereby causing hypernatremia. Sometimes drowning, ingestion of seawater, these can result in hypernatremia. Commonly in our practice in the ER or in the ICU, hypertonic saline infusion, mainly for the correction of hypernatremia, hyponatremia, or in cases of to reduce the cerebral edema, these drugs are given. Sodium bicarbonate infusions during the resuscitation of a patient, sometimes these can result in hypernatremia. Very interesting thing is that certain antibiotics, typically ticarcillin sulbactam, ciprofloxacin, and IV phosphomycin. If you are using these drugs in the ICU setup, you have to remember that these are the group of patients that can develop hypernatremia. So how do you approach a patient with hypernatremia? So you look at the clinical background, you know that these are the patients, these are the group of patients who are prone for hypernatremia. And then you look at the setup, you look at what drugs the patient is using. Has he had a history of any diarrhea? Most of the times that gives you an etiologic diagnosis. But if you have to prove it on paper, the first investigation that we do is to do a urine osmolality. So someone with hypernatremia, with a high urine plasma osmolality, your natural tendency that you expect is that the body tries to retain water. It tries to absorb water. So obviously, you will have a highly concentrated urine wherein urine osmolality will be more than 600 milliosmoles per kg. It tells us that if someone with hypernatremia has a high urine osmolality, it means the water loss is not from the kidney. It is from somewhere else, extra renal loss of water. Whereas if someone has less than 300 milliosmoles per kg, that means the urine is still dilute and ADH is not acting properly. If ADH is not acting properly, that means it is diabetes insipidus. And how do you differentiate between diabetes, whether it is central or nephrogenic, is that you give desmopressin either intranasally or subcutaneously. And if there is more than 50% improvement in the urine osmolality, then it becomes central. And if it continues to be less than 300 and there is no response to your external supplementation of desmopressin, that means the kidney is not responding to desmopressin. And these are the group of patients whom we label them as nephrogenic diabetes insipidus. And the group in between is between 300 and 600 milliosmoles per kg. The diagnosis is either a partial DI or a partial central or a partial nephrogenic diabetes insipidus. So coming to the acute versus chronic hyponatremia, we all know that hyponatremia or hypernatremia, which lasts beyond 48 hours, It is called as chronic sodium disorders. So even for hypernatremia, the definition remains the same. Usually, in our clinical practice, more than 95% of the patients will have chronic hypernatremia, except for few patients wherein the cases that we have discussed, such as salt poisoning, or typically in patients who have central diabetes insipidus, we don't know that these group of patients have that problem. As usual, we keep patients NBM overnight, and when they are taken up for the surgery because of severe duration, severe dehydration during the perioperative period, they are the ones who develop acute hypernatremia because significant water losses happen through the urine. And you also develop hypernatremia during the correction for hyperglycemia in cases of DKA or your HONC. So, in principle, when you approach patients with acute and chronic, let us finish acute first. Not seen in much group of patients. Your target in this group of patients is you have to get the sodium to as low as 145 at the earliest possible, and your hourly rate of sodium correction should not be more than 1 millimole per liter per hour. What is your concern? There is hypernatremia. That means the tonicity of the plasma is high, and when you start correcting and when you start bringing the osmolality typically very fast, there is a tendency for these group of patients to develop osmotic demyelination syndrome. Whereas with chronic hypernatremia, you always want to correct it at a slow rate. Typically, just as in hyponatremia, you also want to correct over here for just 10 millimoles per liter. And even in this group of patients, when you try to correct it very fast, what happens is there is an increased risk of cerebral edema. So just an overview of what is the amount of sodium and what are the preferred units. Now everyone knows that hypernatremia, the best possible fluid that you need to give is 5% dextrose. You have to replace free water. So what is the amount of free water in 5% dextrose? Almost 100%. There are no sodium, no other electrolytes, no other solutes within that water. And all the water that you give is going to go into the extracellular. Extracellular distribution is only 40%. So more, almost 60%. You need to remember that whenever you're giving 5% dextrose, it gets distributed throughout. It goes into the intracellular as well as the extracellular. So equally, so your 60% of your body water is intracellular and 40% is extracellular. That's why 60% goes into the intracellular compartment. That is intracellular dehydration also is corrected. At the same time, your extracellular dehydration is also corrected. Whereas with 0.5 normal saline, it contains almost 77%, and your extracellular distribution outside the cell is almost 73%. Why is it important? 5% dextrose when you're trying to give it to a patient with hypernatremia. Suppose the patient is in hypotension. You can't just say that patient is having hypotension and patient is having hypernatremia. I will just give 5% dextrose. If you give 5% dextrose to such patients, your extracellular distribution is only 40%. So your hemodynamics won't improve. So you are supposed to give normal saline for such patients to improve their hemodynamics. Concomitantly, you are supposed to give 5% dextrose also, so that the patient's hypernatremia is also corrected. Whereas with 0.9%, 100% of 0.9%, if you give 1 liter of normal saline, almost 100% of it is within the extracellular compartment. None of it goes into the intracellular compartment. So the basic things, try to identify the underlying cause. If there is a drug, try to avoid that drug, SGLT2 inhibitors, osmotic diuretics, mannitol, see those. See if there are other electrolyte disorders which are causing the hypernatremia. Culprit drugs like loop diuretics. Why loop diuretics? Among the diuretics that we use, loop diuretics are the ones that act more proximally, and they are the ones that tend to cause more free water loss rather than sodium loss. Why? Because your countercurrent mechanism, your ability of the kidney to maintain the concentration gradient is done by the thick ascending loop of Henle, and that is where the loop diuretics act. So your kidney loses the ability to concentrate or dilute the urine. That is why loop diuretics cause hypernatremia. And if the patient is on lithium, it is obvious that you have to stop it. And in case of nephrogenic diabetes insipidus, wherein your vasopressin is not acting, in such patients, you try to use thiazide diuretics and you give the patient a low sodium diet. That is, I'm not going to go into the details of management, but these are the outlines. Recently, NSAID also tend to help in nephrogenic diabetes insipidus. Recently, acetazolamide has been proven to be useful in lithium-induced nephrogenic diabetes insipidus. Volume overload and hypernatremia. We tend to fight with our cardiology colleagues, and this is a area of contention. Typically, someone with cardiac failure, patient comes with a lot of peripheral edema. At the same time, he is in pulmonary edema, and you want to give diuretics, but patient is having what do you say, hypernatremia. In this group of patients, it is very important that you have to, as we have discussed in the first slide, volume overload is a disorder of your effective arteriolar volume. So you have to make sure that you give diuretics. Hypernatremia is a disorder of water. You have to concomitantly give water. Or the only other way that you can correct this group of patients is to initiate them on dialysis. So if you want to avoid dialysis, you have to manage both the compartments separately and make sure that the patient is treated. So how do we replace? This is the mnemonic. Okay. Yesterday plus today is equal to tomorrow. What is the usual mistake that we do? There is hypernatremia. That means there is significant free water loss. More often than not, we don't see patients with sodium ingestion. So for all practical purposes, in our regular practice, more than 90% of the patients come with some form of dehydration. That is loss of free water loss. In such patients, our aim is to replace the water. At the same time, we also need to make sure that the ongoing losses are also corrected. So what is the free water deficit? You calculate that. How much patient must have already lost? Second, how much is he losing on a day-to-day basis? You have to correct both of them and calculate it accordingly. So let's uh, deconstruct this, how it is going to be. So when we are calculating free water deficit, there are various formulae that have been proposed. However, the latest guidelines and the recent plan to how to manage these patients is they have simplified things. See, 60% of our body weight is water. So when we calculate total body water, 60% is for men, 50% is for women. Why is it so? Because women tend to have a lesser muscle mass, and your muscle is nothing but lot of water. So obviously, for men, the percentage of total body water is higher, and for women, it is less. So when you are calculating your free water loss, what happens is there is a complicated formula wherein you tell the amount of urine volume into 1 minus urinary sodium plus potassium divided by serum sodium. This is a complicated thing. But if you look at this is usually done in patients with diabetic insipidus. Suppose someone is having significant diarrhea, they will not be making so much of urine. In patients with diabetic insipidus, particularly in the ICU setting, they'll be making 3 liters, 5 liters, 6 liters of urine. So you start correcting. There is a formula. Patient is having a sodium of 170. You start correcting, but the patient is also losing 6 liters per day of water. So you have to calculate already whatever is deficit, how much is he losing. In such patients, the simplest mechanism is, so for the first 1 liter, you replace equal amount. So patient has a urine output about 5 liters, say. So the first 1 liter, you don't replace any free water. For 2 to 3 liters, you replace half of it. That means 2 to 3 is second and third liter. Half of it is 2 liters. And then for more than 3 liters, you give 2 liters. Okay. So that it will come to around beyond 3 liters, you will replace more than this. Suppose if someone is having 6 liters of water, urine per day, 5 liters of urine. So that is, so the first 1 liter, you don't replace anything. For the next 2 liters, you replace half of it. And then every liter beyond 3, you replace that. Yes. So let us calculate how we do your free water deficit equation. So this free water deficit equation, suppose someone presents to you with diarrhea for 3 days and their serum sodium is 175. When you're calculating for 175, 175 minus 140 divided by 140 into total body water. So your free water deficit is coming to around 7.5. Now, I cannot give this 7.5 liters in a single go, except if I know that this has developed within less than 2 days. Only in acute hypernatremia, you want to correct the entire total body water within 24 hours so that this patient sodium has to come down immediately to 145. As we have discussed earlier, only in acute salt poisoning or in patients like your severe honk or this, wherein you need to replace it very fast, you don't correct it at a faster rate. For all practical purposes, wherever there is chronic hypernatremia, you want to correct it over, say, 10 per day. So if 7.5 liters is the amount of fluid deficit, which will correct this deficit from 175 to 140. That is, if you give 7.5 liters, you will correct the sodium by, say, 25, and you want to correct it over 4 days so that you will do it only by 9 milliequivalents per day. That means you have to suppose to give 1.875 liters per day. And to that, you are going to add 500 ml of insensible losses, or that 30 to 40 ml per kg, whatever we have discussed, and the ongoing losses. Suppose if the patient is having a lot of urine output, based on the formula that I have told, based on the amount of urine, for the first 1 liter, you don't replace anything. 1 to 2 liters, you replace half of it, and thereafter, full of it. So 2.5 liters per day is the total. 1.875 plus 500 is approximately coming to 2,400. So you are going to give this 2,400 over 24 hours. So 100 ml per hour is the volume that you are supposed to give. And if in case a patient is having hypotension, then this is not the fluid of choice. Along with hypernatremia correction, you're also supposed to give normal saline so as to correct the hemodynamics, only till you correct the hemodynamics. So the easiest way that is now in vogue and which is more practical is based on the rationale that for every 1 millimole per liter decrease in the serum concentration, it requires 3 ml per kg of electrolyte-free water. So say you give 3 ml per kg of 5% dextrose, you are going to reduce the serum concentration by 1 millimole per liter. So if the target fall, so our guideline is we are not supposed to correct it more than 10 per day. So in 24 hours, if you calculate it, 3 ml per kg into 10 in 24 hours, if you divide it per hour, it will come to around 1.35 ml per kg per hour. So for any patient with chronic hyponatremia, blindly, you can start off correcting at this rate. That is 1.35 ml per kg per hour. Monitor the sodium every 6th hourly, and accordingly, you can increase or decrease your sodium correction. Why this is important is this is more practical rather than calculating the deficit, trying to correct it, because most often we are not going to get the adequate correction or the exact correction that is expected from the formula. And the other formula that we need to learn, but not that much useful in our clinical practice, is how much is a change in the Adrog-Madias formula. I hope all of you are aware of this. However, this does not predict the changes in serum sodium in a group of patients with hypernatremia, wherein there is severe extracellular volume depletion and someone with a kidney failure. Obviously, suppose with hypernatremia with a raised creatinine, you don't expect that this formula will be accurate. So to summarize, in hypernatremia, you want to get the sodium to as low as 145 at the earliest possible. And then once you reach, so for us to get it, you have to give it at around 3 to 6 ml per kg per hour. Whereas in chronic hypernatremia, you give at 1.35 ml per kg per hour to a maximum of 150 ml. How often do you monitor? 3 hourly in acute hypernatremia, whereas you have to monitor almost 6 hourly in chronic hypernatremia. And you increase or decrease the infusion dose based on the rate of decline of the sodium. So what are the problems with hypernatremia when you are giving 5% dextrose? Suppose the patient already has high sugars or there is a lot of stress. In such patients, you try to use 0.45 normal saline, and the rate at which it increases, it provides. So as we discussed, 3 ml per kg per hour of 5% dextrose will be equivalent to 6 ml per kg per hour. So these are simple bedside things that will help us in handling our patients. So, like in hyponatremia, we are all aware that it's been enforced in our brains. If you correct hyponatremia very fast, you will get osmotic demyelination syndrome. Similarly, with hypernatremia, if you are overcorrecting hypernatremia, the mortality and the problem is not as much as that you see in hyponatremia correction. So for all practical purposes, most often, we always undercorrect hypernatremia rather than overcorrect hypernatremia. Okay, suppose in case we even overcorrect hypernatremia, the mortality or the complication is not that much. Only in pediatric population, your rehydration seizures are more common. In adults, it is not that much of a risk. However, the theoretical complications are your cerebral edema and rehydration seizures. More often, we undercorrect hypernatremia, and the complication for that is your osmotic demyelination syndrome. So, to summarize and to complete it, symptomatic hypernatremia will not develop in a patient with intact thirst and access to water. When you're evaluating hypernatremia with urinary osmolality, you have to see what is the level. If it is more than 600, then it's a normal non-renal loss of free water. And if it is less than 300, you have to search for diabetes insipidus. Always make sure that when you're calculating fluid deficit, also see if there is any ongoing losses and try to correct that thing. Try to correct it using free water, mainly with 5% dextrose. Also, you have to put in oral water, and you can divide the fluid as oral water, 5% dextrose, and see the sodium every 6th hourly, and you can increase and decrease your water replacement accordingly. And you need to understand that the two compartments, that is a basis for this class. Sodium disorders per se are not sodium disorders of by sodium themselves. They are disorders of water, and that entire compartment of ADH drives the sodium disorders. Whereas volume overload or volume depletion are disorders of your effective arteriolar circulation and your RAS activation and sympathetic activation. And these two compartments concomitantly work together separately. They run parallelly, and you need to address each of them separately. I'm happy to take any questions.
Sir, there's one question.
Yeah.
The question is, sir, can you please tell about hyponatremia correction? Like how much ml of 3% NaCl should be given if the sodium is, for example, 112? They're asking for about hyponatremia.
So, as we discussed, again, the same Adrox-Medias formula, there are various ways in which we use. We calculate the sodium deficit. And if I give 1 liter of 3% sodium chloride, which has about 513 millimoles per liter, if I give 1 liter of 3% sodium chloride to a patient who is having, say, so for example, I think my screen is not working.
We can see the screen still.
No, I think my PowerPoint. So if you take the Adrock-Medias formula, according to that particular thing, you have to calculate. First and foremost, any patient with hyponatremia, you want to know whether it is acute hyponatremia or chronic hyponatremia. Second thing, whether this patient, when you're trying to correct hyponatremia, your target is not more than 10 millimoles per liter per day. You don't want to correct beyond that, because these are the group of patients who are going to develop osmotic demyelination syndrome. If possible, as students, we are always supposed to calculate what is the sodium deficit. Use the Adrox-Medias formula. It will tell us that this is the deficit of sodium, and accordingly, you start correcting how much amount of sodium, if you give per hour, will correct it at the end of 24 hours. If you want to correct 10, how much is the volume that you want to give over 24 hours? The most practical way that I would tell you is that you start correcting sodium, repeat the sodium every 6 hourly. In fact, they say check it every second hourly for someone who has acute symptomatic hypernatremia. Now, the latest guidelines say give 100 ml of sodium every 20 minutes, at least 3 doses, until you improve the serum sodium by 5 millimoles per liter, so that your hypernatremia, someone presented with seizures, you want to correct the sodium by 5 millimoles per liter over the next 6 hours. That is what you're supposed to do. However, in the ICU or in the ER setting, when you are faced with a hyponatremia situation, always try to calculate what is the sodium deficit. Start correcting the sodium with 3% sodium chloride. Suppose based on the formula, you are getting it at 15 ml per hour. Then you start correcting it. But at the end of 6 hours, you know that you are over correcting it or you are under correcting it. That is when you know that you're going to reduce your sodium, you're going to stop your sodium load. We need to understand that hypernatremia is a different ball game compared to hyponatremia. With hyponatremia, what happens is there are a certain group of patients, particularly once you start correcting sodium, there is the stimulus for ADH is gone. So these are the group of patients who will suddenly diurese, particularly if someone has dilutional hyponatremia or SIADS, they will start producing a lot of urine. So there is a lot of free water loss. So once you start raising the serum osmolality using 3% sodium chloride, when your free water loss is significant, know that your patient's sodium is going to get corrected at a faster rate. Typically happens someone with hypovolemic hyponatremia. Suppose someone has presented with a lot of vomiting, 112 sodium, you start correcting it. As the serum osmolarity is improved, you don't need to give anything else. The system automatically corrects because your free water replacement, whatever was there, that water starts diuresing. So always look at your patient's urine output when you're correcting hyponatremia. If the urine output is significant, that means that particular patient is going to get his sodium corrected more faster than any other patient. I hope I'm just giving you practical advice because the rest of it you can read.
Yes. Are there any other questions? Okay. Thank you for such crisp presentation, sir. You have definitely made few of our concepts more stronger. And you have definitely made few of the formulas easier to us, especially the rule of thumb correction which I've spoken about, 1.3 ml per kg. Probably that can be immediately started just before the calculations. So
Yeah.
definitely, this will definitely help us, sir. Just a question from my end, sir.
Yeah.
So of course, if you're suspecting hypernatremia, we're going to send for urine osmolality, urine sodium levels. Are there any other investigations that we should keep in mind in ED setup that we need to send? For example, ADH levels or anything like that.
I don't think so because now there is.
Okay.
I know what I get you. So there are now latest things that are measuring your ADH level, and then the copeptin levels is what is in vogue now. Theoretically, these are good MCQ questions wherein what are the levels. Suppose if your ADH levels are high, that means there is no central diabetes insipidus. You can rule out central diabetes insipidus. But as of now, the more practical way is to just see if your urine osmolarity is high or low. If it is high, you rule out a renal cause of the problem. If it is low, then there is the water loss through the kidney, whether
Mm.
it is diabetes insipidus or nephrogenic diabetes insipidus, you will get to know after water deprivation test. But for us, it is very important that in the ICU setting or in the ER setting, the background is very obvious more
Mm.
often than not. You know that someone is in the rehabilitation center, elderly gentleman, kept at home, not given feeds properly, or someone who is very drowsy, not taking adequate water. You clearly know that this particular patient has not had water. So the moment they come, your first thing in the ER is you start correcting that particular thing. Try to look at the drugs. I think this
Yes.
presentation should help us to. It is not a perfect presentation, so that you will directly go. You read on these topics, and as and when a case comes, try to apply that, and that's how we become more uh, vigilant, and it becomes a great thing in our practice.
Thank you once again for the presentation, sir.
Thank you. Thank you so much.
I think we can close the session.
Sure. Thank you.
Thank you, sir.